This film is intended for eye surgeons for training and education purposes. Viewer discretion is strongly recommended. I'm Dr. Deepak Megur, and today I'll be sharing with you a case about a 70-year-old man who had sustained blunt trauma many years back. Now he has an intermittent cataract with around 3 to 4 clock hours of zonular dehiscence. So I begin my case by doing 2 small paracentesis. At this stage, I'm not sure if it's vitreous prolapse or not. I'm using trypan blue as little as possible to stain the anterior capsule. At this moment, I see there is some amount of trypan blue which is egressing out from the area of the zonular dehiscence, and I become suspicious, and I'm now injecting a diluted triamcinolone acetate to check for the presence of vitreous. And as we can see, there is a tongue-shaped vitreous which is prolapsing from the area of the zonular dehiscence. So the first thing to do in such a scenario is to ensure that we do antivitrectomy and remove all the prolapsing vitreous. We can't proceed with the vitreous prolapsing out like this. So using a very low flow rate and high cut rate, I am doing antivitrectomy to ensure that the vitreous is cleared off. The high cut rate and very low flow rate ensure that we don't cut the iris and the anterior capsule, and they are prevented from damage. I am plugging that area of zonular dehiscence by using a dispersive OVD. Under this, I'm using a cohesive OVD. Push back the anterior capsule so that I can get a rhexis done easily. During rhexis, I realized that the rest of the zonules are quite healthy. The capsulorhexis could be done quite easily. I'm aiming to do a rhexis of about 4.5 to 5 millimeter. The smaller rhexis is going to help me to achieve optic capture if the need arises. And the rest of the zonules look to be quite healthy in this situation, so the rhexis is completed. Capsule hook to engage that area with zonular dehiscence. I'm making another side port to introduce my chopper. Again, I'm using dispersive OVD to block that area. So now I'm implanting the CTA. I always support the ring with my left hand using a Sinskey hook, and the last part of the ring is dialed in by using another Sinskey hook. And my strategy is to do a direct chop. So once I bury the phaco tip into the nucleus, I'm trying to chop the nucleus and realize that it's quite dense. My right hand is stable, and I'm just trying to use my left hand to separate the nucleus and try to break the posterior fibers. Again, the strategy is here to keep my right hand stable and try to separate the fragment using the left hand. The difficulty in eyes with these loose bags is that you don't have the counter traction which is so helpful in separating them, because the tensile strength of the bag is not much here. So it is now the final 2 fragments are emulsified quite easily. White plaque which you're seeing behind the posterior capsule actually is the vitreous which was stained with the triamcinolone acetate which we had used, and we can see there is still some amount of vitreous being prolapsed to that area. At this point, I thought the best way to tackle this is by using a Passplan approach, because we can access the vitreous from behind and then do decent antivitrectomy. So 3 millimeter from the limbus, I make a sclerotomy using AMVR plate just behind my scleral tunnel incision which I had created, and again using my 23G cutter and infusion through the antechamber paracentesis, I proceed to do a limited anterior vitrectomy. Care is taken that I remove all the vitreous which is there adjacent to the area of the zonular dehiscence, and also I'm cautious that I don't damage the posterior capsule. So just enough to ensure that it doesn't prolapse through the zonular dehiscence. At this stage, I'm closing my sclerotomy using an A2 vicryl. Now is the time to implant the lens. I'm using sodium hyaluronate to create some space. The plan again is to implant the multi-piece lens with the haptic in the sulcus and then trap the lens behind the rhexis margin to achieve an optic capture. So first, it's important and critical that we go back behind the lens and remove the OVD which we have used it. Once the sodium hyaluronate is removed, now we need to tuck the lens back posteriorly, and once it is done, you can see there is some amount of a vitreous which is again prolapsed to that area. I'm using my vitrector to do vitrectomy, and you can see the ovalization of the rhexis, which is suggestive of the fact of the optic capture.